Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 256 of our pharmacotherapy series, which majors in sexually transmitted diseases. The first question reads, CMB is a 24-year-old, sexually active, homosexual man with a 2-month history of perianal itching, painful defecation, constipation, a bloody mucoid rectal discharge, and a sore throat. Sigmoidoscopy revealed rectal mucosal inflammation but no apparent ulcers or fissures. Stool examination for parasites was negative and a venereal disease research laboratory, abbreviated as VDRL, test was non-reactive. Both rectal and pharyngeal cultures revealed Neisseria gonorrhoeae. How does gonorrhea in homosexual men compare with gonorrhea in heterosexual men? Rectal infection occurs rarely in strictly heterosexual men, whereas in the male homosexual population, anorectal 25% and pharyngeal 10% to 25% gonococcal infections occur more often. Because pharyngeal and anorectal gonococcal infections are often asymptomatic, a large reservoir of carriers in the homosexual male population may exist, and annually screening should be done if they have engaged in receptive oral or anal intercourse in the preceding year. By comparison, very few urethral gonococcal infections are asymptomatic. In addition, data indicate that pharyngeal infections may be an important source of urethral gonorrhea in homosexual men, spread by fellatio. The next question reads, are CMB's signs and symptoms consistent with gonorrhea? Rectal gonorrhea produces the syndrome of proctitis with anorectal pain, mucopurulent anorectal discharge, constipation, tenesmus, and anorectal bleeding. The differential diagnosis of proctitis in the homosexual male includes rectal infection with N-gonorrhoeae, chlamydia trachomatis, HSV, and syphilis. Proctitis, limited to the distal rectum, should be differentiated from proctocolitis, which is often caused by Shigella species, Campylobacter species, or Entamoeba histolytica in homosexual men. The incidence of rectal gonorrhea and chlamydia has risen dramatically since 1996. Rectal chlamydia is often asymptomatic and observed more often than gonorrhea, necessitating testing for both pathogens. Although pharyngeal gonorrhea is often asymptomatic, a review of system and physical exam may reveal a sore throat, pharyngeal exudates, or cervical lymphadenitis. The next question reads, how should CMB's diagnosis be managed? The treatment of choice for patients such as CMB with anorectal or pharyngeal gonorrhea is ceftriaxone 250 mg IM as a single dose. Azithromycin should also be given to treat possible coexisting rectal chlamydial infection. Patients, such as CMB, with either anorectal or pharyngeal gonorrhea should be advised to avoid further unprotected sexual activity and should be counseled and tested for infection with HIV. The next question reads, what are the alternative regimens for patients with isolated anal or pharyngeal gonorrhea? Patients with anorectal gonorrhea alone should be treated with ceftriaxone. Oral cefixime is a recommended alternative, but it should not be used as a first-line agent. As with urogenital infections, alternative regimens for isolated anorectal infection include a single-dose cephalosporin regimen, such as ceftriaxone. Because spectinomycin is unavailable, patients with anorectal gonorrhea, who are allergic to penicillin or cephalosporins, should be desensitized before treatment is initiated. Patients with gonococcal infections of the pharynx should be treated with ceftriaxone. However, infections of this nature are more difficult to eradicate than infections at urogenital and anorectal sites. Treatment for gonorrheal infections at these sites should also be treated with azithromycin for presumptive chlamydial co-infection. The next question reads, what measures have been used to prevent the sexual transmission of infection? Condoms, when used properly, seem to provide a high degree of protection against the acquisition and transmission of STDs. Previous studies indicated that the use of the spermicide nonoxynol 9 had activity against gonorrhea and chlamydia. However, in light of recent evidence suggesting that nonoxynol 9 might actually increase the risk of acquiring HIV and other STDs, the FDA currently requires manufacturers of nonoxynol 9 products to include a warning statement on the product's label that it does not protect against HIV or other STDs. Topical antibacterial agents, urinating, and washing after intercourse are of little value in preventing the transmission of STDs. Douching may increase the risk of other STDs, such as trichomoniasis. The prophylactic administration of antibiotics immediately before or soon after sexual intercourse is not recommended owing to increased costs and antimicrobial resistance. Use of rapid, specific tests and empiric symptomatic management enhances detection and treatment of gonorrhea. The next question reads, HCC, a 19-year-old, sexually active woman, complains of mild dysuria, a purulent vaginal discharge, fever, and moderately severe, bilateral, lower abdominal pain of 3 days duration. Examination confirms uterine and adnexal tenderness, a purulent cervical exudate, and a temperature of 39 degrees Celsius. Laboratory examinations show a non-reactive VDRL and negative urinalysis. A pregnancy test performed was negative. The peripheral WBC count was mildly elevated, that is 11,000 per microliter, with 70% polymorphonuclear leukocytes. So my question to you is, does HCC have PID? How should she be treated? Although fever and leukocytosis are often absent in mild or subacute PID, these findings in a woman with uterine and adnexal tenderness with cervical exudate increases the likelihood of acute PID. Recommended treatment regimens for PID should be initiated immediately after diagnosis of PID to prevent clinical sequelae. Confirmation of the actual pathogen rarely takes place. Patients such as HCC with mild to moderate PID can be hospitalized and treated with parenteral antibiotics. However, clinical efficacy and overall outcomes are equal between parenteral and oral therapy, and HCC could also be treated on an outpatient basis. For inpatient treatment, the CDC recommends either intravenous IV cefotatin 2 grams every 12 hours or IV cefoxitin 2 grams every 6 hours for at least 24 hours beyond the first signs of clinical improvement, along with doxycycline 100 mg every 12 hours. Once clinical improvement is noted, parenteral therapy may be discontinued and oral doxycycline 100 mg every 12 hours can continue to complete 14 days of therapy. For outpatient treatment, the CDC guidelines recommend either IM ceftriaxone 250 mg as a single dose or IM cefoxitin 2 grams as a single dose with probenecid 1 gram orally for 1 dose, plus oral doxycycline 100 mg twice a day for 14 days with or without oral metronidazole 500 or 400 mg twice daily for 14 days. A tetracycline derivative or an alternative agent that is active against Chlamydia trachomatis should be included in the treatment of PID. However, monotherapy with a tetracycline is not recommended because of the lack of activity against gram-negative aerobic and anaerobic organisms and Neisseria gonorrhoeae. The addition of metronidazole, which covers anaerobic bacteria, should also be considered. Anaerobes have been isolated from the upper reproductive tract of women with PID and may cause tubal and epithelial destruction. Metronidazole is widely used by clinicians, because bacterial vaginosis is frequently associated with PID. Fluoroquinolones, such as levofloxacin and ofloxacin, are no longer recommended for the treatment of PID because of the increase in prevalence of QRNG in the United States. Both oral and IV doxycycline have similar bioavailability, therefore, doxycycline should be given orally whenever possible. Substantial clinical improvement is usually seen within 3 days after initiation of therapy. Clindamycin plus gentamicin can be used alternatively in penicillin-allergic and pregnant women. Because HCC is sexually active, any sexual partners within the previous 60 days, or if longer than 60 days, then the most recent sexual partner should be empirically treated because of the risk of gonococcal or chlamydial urethritis as well as to reduce the risk of reinfection. The next question reads, SSP, a 28-year-old, sexually active woman, was seen for stiffness and pain of the right wrist and left ankle and fever of 38 degrees Celsius. On physical examination, the knee and wrist joints were found to be hot, red, and swollen. Papules and pustular lesions were observed on SSP's legs and forearms. A latex fixation test for rheumatoid factor was negative. A tap of the right knee yielded an effusion with a WBC count of 34,000 per microliter with 80% polymorphonuclear leukocytes. Cultures of the skin lesions were negative, but Neisseria gonorrhoeae was isolated from the throat, cervix, blood, and synovial fluid. A chest radiograph, echocardiogram, and electrocardiogram all were normal, and no murmur could be appreciated. I would like you to assess SSP's clinical presentation. SSP's signs, symptoms, and laboratory findings are consistent with gonococcal bacteremia, which today occurs in less than 1% of women and men with gonorrhea. The most common manifestation of gonococcemia is the gonococcal arthritis dermatitis syndrome or disseminated gonococcal infection exhibited by SSP. Symptoms include fever, occasional chills, a mild tenosynovitis of the small joints, and skin lesions, the latter primarily involving the distal extremities apetocyle, papula, pustula, and hemorrhagic in appearance. Diagnosis of disseminated gonococcal infection is made by nucleic acid amplification test or culture of specimen from routine sites of gonococcal infections, e.g., urethra, cervix, pharynx, and rectum, as well as culture from disseminated sites of infection, e.g., synovial fluid, blood, skin, and CNS. However, blood cultures are positive in only 33% of disseminated gonococcal infection cases, even when culture samples are obtained early in the course of the infection. The low positive yield from blood cultures may be attributable to the low inoculum or intermittent bacteremic period. The next question reads, how should SSP be managed? How quickly will she respond to therapy? Patients like SSP with gonococcal arthritis and bacteremia should be hospitalized for treatment with ceftriaxone 1 gram IV or IM daily until substantial clinical improvement is sustained for 24 to 48 hours, at which time therapy may be switched to an oral agent guided by antimicrobial susceptibility for a total treatment course of at least 7 days. Initiation of treatment should also include azithromycin 1 gram orally in a single dose. Symptoms and signs of tenosynovitis should be improved markedly within 48 hours. Septic gonococcal arthritis with purulent synovial fluid may require repeated aspiration and resolves more slowly. The next question reads, how should gonococcal endocarditis and meningitis be treated? Regarding the treatment of gonococcal endocarditis and meningitis, gonococcal endocarditis and meningitis, occurring in only 1% to 3% of disseminated gonococcal infections, require high-dose IV therapy, such as ceftriaxone 1 to 2 grams IV every 12 to 24 hours, for 10 to 14 days in the case of meningitis and for at least 4 weeks in the case of endocarditis. Like other gonococcal infections, a single dose of azithromycin 1 gram orally should be given. The next question reads, how should neonatal disseminated gonococcal infection and meningitis be managed? Neonatal disseminated gonococcal infection and meningitis can be treated with either ceftriaxone 25 to 50 mg per kilogram IV or IM daily or cefotaxime 25 mg per kilogram IV or IM every 12 hours. Treatment is for 7 days for disseminated gonococcal infection. However, meningitis requires 10 to 14 days of treatment. Although ceftriaxone is also effective in the treatment of neonatal disseminated gonococcal infection and meningitis, cefotaxime is considered a safer choice in the neonatal population. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 257.